Good afternoon, ladies and gentlemen. It's welcome to the first media briefing at the Free Market Foundation for 2016. It's fantastic to see so many people here. I must admit that I always find presentations on healthcare to be somewhat difficult because it's such an emotive topic. But I don't think it takes someone trained in the economics profession to understand that there's something seriously wrong with the mantra of free healthcare for all. So whilst I was reading through the white paper, I was reminded about this quote by Professor Thomas Sowell, who said, "It's amazing that people who think we cannot afford to pay for doctors, hospitals, or medication somehow think that we can afford to pay for doctors, hospitals, medication, and the government bureaucracy to administer it." Just before I get into some of the background, I just think that I'd like to rewind a bit. I found the timing of the release of the NHI white paper really intriguing. I mean, it's considering that this is something that's going to affect not only each and every one of us in this room, but also our children, grandchildren, and generations to come. And as the white paper puts it, it represents a substantial policy shift that will necessitate a massive reorganization of the current healthcare system. As I was saying, it really was intriguing when they released the NHI white paper, because it came at a time when we had 3 finance ministers in the space of 1 week. The rand was plummeting, investors were frantically pulling out resources, both foreign and domestic, out of the economy, and the economy was and largely remains in economic turmoil. And you would think that a policy that requires extracting billions of rands from taxpayers would be released at a time when there's an abundance of confidence in the future of the country. Not at a time when there's blood on the streets and all of the economic growth forecasts are all dismally bleak. I was also intrigued to, whilst I was reading through the white paper, to see what's changed since the green paper. And immediately from the cover page, you'll notice that the NHI white paper had 40 different versions. There was so-called extensive public consultation that occurred, and no less than 4 years has elapsed since the publication of the green paper, but all of the fundamentals in the white paper are exactly the same. We're still no closer to understanding how it will be funded, exactly funded, and what the costing implications are. So I think this is a good time to look back and see what healthcare professionals thought about the NHI Green Paper. And here I'm relying on a survey conducted by the Pension and Provident Society of South Africa. They call it the Professional Confidence Index Survey. And for the purposes of this media briefing today, I was most interested in a series of questions that they asked pharmacists. So they got responses from over 200 pharmacists to the following 2 questions. Do you agree that NHI is the right scheme to fix the country's ailing healthcare system? And do you agree with the principle behind NHI? An overwhelming majority of the respondents, 81%, said that they did not believe that NHI scheme is the right solution to fix the country's ailing healthcare system, and over half of the respondents did not agree with the principle behind NHI. And these results were actually largely mirrored by professionals in general. So here again, I'm relying on one of the Pension and Provident Society Professional Confidence Index surveys. This time it was conducted in 2015. And they asked attorneys, doctors, engineers, all sorts of professionals. They received responses from over 3,500 individuals to the question, how confident are you about the future of the healthcare system in South Africa over the next 5 years? Immediately what we can tell, or what we can see, is that there are really low confidence levels in the future of healthcare in South Africa. Only 45% of the respondents are confident in the future. And there's also a downward trend that's been happening. And I think this is directly related to the fact that professionals have this uncertainty with regards to the government's ability to actually implement the NHI scheme. And here again, I'm reminded about this quote by PJ O'Rourke, who said, if you think healthcare is expensive now, wait until you see what it costs when it's free. Before we get into some of the details on the NHI white paper, I'd like to talk about some of the consequences. And specifically, I'd like to point out that once a law is adopted, it's very difficult to repeal. And in my opinion, incremental improvements are much better because the positive effects have a much that the government simply will not be able to cope with. And I think it will impose an unnecessary and intolerable burden not only on taxpayers but on governments as well. So before the government even contemplates introducing the big bang approach to healthcare reform, I think it should more carefully consider the economic circumstances within the country. I briefly alluded to some of these issues in my opening remarks, but for the purposes of today's media briefing, I'd really like to just focus on one of the issues, and that's South Africa's chronic unemployment problem. If we look at Statistics South Africa's quarterly labour force survey, according to the latest available data, we see that about 25.5% of the country's working age population is unemployed. So this means that there are about 5.5 million people that are unemployed. But I don't think this is a very good indicator of what's actually happening on the ground, because 2/3 of the unemployed have been unemployed for longer than a year. So in my opinion, a much better indicator of what's actually happening on the ground is the so-called expanded definition of unemployment, which includes the so-called discouraged work seekers. And these are people that have simply given up searching for work because they don't believe that there's any work available. So according to the expanded definition, we find that there are about 35% of the working aged population is unemployed, which means that there are over 8 million unemployed people in South Africa. As a result of this massive unemployment problem, South Africa suffers from really low income levels. And I think it should be noted that the twin evils of income inequality and poverty are inextricably linked to this massive unemployment problem in the country. And despite these and other glaring problems, you can think about Eskom, South African Airways, the rand volatility, as well as the dismal economic growth outlook, which, by the way, could result in another ratings agency downgrade. And then if that goes ahead and we don't improve things, then we could actually face the very dire situation of having to ask the IMF for a bailout. So despite all of these issues, the government is going ahead and it's implementing national health insurance. In fact, we're ending the first phase. We're nearing the end of the first phase of implementation of the NHI. And I think this in itself raises a whole lot of questions regarding whether or not the due process around the legislation is actually being correctly followed. So I think one of the big questions is, can South Africa afford national health insurance? And here it's instructive to go back and have a look, see what history said. So if we go back as far back as 1944, the South African government considered the ambitious idea of introducing a fully tax-funded national health service to provide free healthcare for all. But that policy was never adopted because primarily due to a lack of funding. And over 70 years later, the ambitious proposal is still not a feasible option. More importantly, I don't think it's either necessary or appropriate for the government to assume responsibility for the health of the nation. I think the very idea of national health insurance fuels this erroneous general perception that government is the foundational source of health and is thus entitled to regulate our individual activities as well as providers' activities. It might also be worthwhile taking a look back and seeing what Professor Anne Mills said. She was formerly the head of Health Economics and Financing Program at the London School of Hygiene and Tropical Medicine. And this paragraph formed part of her inputs into the 1994 Finance Committee, which was actually established by the Department of Health to advise on national health insurance. She says it's clearly financially unaffordable to offer universally either the benefits currently on offer in medical aid schemes or free and complete in the public sector. Benefits would therefore have to be severely restricted. However, it's difficult to see how this can be achieved because the setting up of a universal scheme would raise expectations about access to care. Moreover, the scheme would put in place a financing mechanism before having in place the health service infrastructure to satisfy demand. Benefits would inevitably be unevenly available, causing justifiable grievance. Over 22 years later, I think everything contained within this one paragraph is still applicable to this day. So what are the funding sources that have been identified within the NHI white paper? Well, there still actually isn't any certainty regarding exactly how it is that the NHI will be funded. But it's been suggested that it will be funded either through a surcharge on taxable income, a specific progressive payroll tax for income tax earners above a minimum tax threshold, an increase in VAT, or some combination of those three. Now, before the government even contemplates introducing another tax, or at least raising an existing tax, perhaps it would be more prudent to carefully consider the country's economic circumstances. So let's go through each of these ones in turn. What about an increase in VAT? VAT is a regressive tax. Whether you're rich or poor, the amount we pay on any given product as a percentage of its price is the same. In other words, the burden forms a larger share of a poor person's income than that of a rich person. So an increase in VAT will not only make poor people worse off, but it will increase income inequality in the country. And the Davis Tax Committee actually, which the NHI white paper relies upon, acknowledges these facts. Poor people will be made worse off by increasing VAT, and will increase income inequality. So in my opinion, increasing VAT will not only retard economic growth and exacerbate South Africa's massive unemployment problem, but it will also raise inflation and increase inequality, which is precisely the opposite of what we want to do if we want to be helping the poor. What about the other proposed taxes? So here you can lump these together into increase in tax on individuals. I think most of us in this room understand that taxes interfere with the ability to achieve our goals. And one of the recurring themes throughout the white paper is that increased economic activity is key. And this is repeated often. And I'll come back to this later, but at this point I'd like to point out this quote. It comes from paragraph number 114 in the white paper. It says, increased economic activity ultimately contributes to poverty alleviation, better quality of life, and human development, and will reverse the significant income inequalities in the country. And I think that's an important point. Economic activity increased economic activity is key. So what's one of the best ways to boost economic activity in the country? It's to reduce taxes and to encourage savings and investment. Because you must remember that a lack of investment in the economy retards capital accumulation, and a lower capital to labor ratio means that real wages will be lower, and if real wages are lower, it means that there's going to be less savings and investment. So it completes this vicious cycle. In other words, if I was to put it simply, I'd say that without the investments to fund new ventures and to create the jobs, the smaller the economy will be, and the lower the economic growth rate or economic activity rate will be. So I think government would therefore do well to avoid inflicting further pain on South Africans by imposing yet another tax or increasing taxes even further. And the white paper actually acknowledges as much. It states that payroll taxes add to the cost of employment, and the impact of higher payroll taxes on overall employment and job creation has to be considered carefully. High payroll taxes can lead to a bias against formal sector employment and increase in informal and unprotected work. It goes on to state that a higher overall personal income tax burden would impact on the disposable income of households and on consumption expenditure and economic activity. A further concern with this option is the potential negative impact on savings. And finally, with respect to funding, the NHI white paper states that the financing requirements are uncertain. So let's try and add a bit of certainty. And here I'd like to draw your attention to a joint publication between National Treasury and the South African Revenue Service. It has the bland title of Tax Statistics 2015. And according to this joint publication, we see that about 16.8 million people are registered for personal income tax in South Africa. But just because someone's registered for tax doesn't mean that they actually pay tax. Of course, everyone pays tax via VAT, but personal income tax is the main source of government's tax revenue, and it's also the main financing vehicle proposed for the NHI fund. So of the 16.8 million people that were liable to submit tax returns, there are 6.6 million rather that were liable to submit tax returns. If we disaggregate that data, we find that the top 10% of income taxpayers in the country, which is about 480,000 people, so I'm referring to the red triangle at the bottom of this inverted pyramid, they account for over half, 57% of the total personal income tax take in the country. If we include people with incomes in excess of 120,000 Rand per annum, or taxable incomes in excess of that, we see that there are about 3.4 million people in South Africa are responsible for 99% of the total personal income tax take. I hasten to add that the publication does point out that there's significant upward social mobility evidence in the tax records, which indicates that South Africans, well, at least those that are registered for tax, are getting richer. And that's a very important point and something that I'd like to return to later. But what should be clear from what I've just been talking about is that South Africa has a really narrow tax base. And interestingly, the white paper says the following. A narrow tax base requires higher tax rates, while a relatively broad tax base requires lower tax rates to generate the same amount of tax revenue. To the extent that high tax rates tend to cause distortions, lower rates and a broad tax base should be preferred. So, given South Africa's narrow tax base, I think it's surprising that the government is even contemplating increasing an already overburdened tax base rather than trying to get more people actively involved in the workforce. So one of the big questions on everyone's lips is how much will NHI cost? And here the white paper figures say that the figures that they present are based on a modified costing of the NHI green paper. And I think this leads to the question, where is the Treasury's analysis? Remember that the Treasury's analysis was supposed to be done in conjunction with the release of the white paper, but I haven't seen it. I don't think it's been released yet. And it also leads to the question, what are the figures based on? Because the so-called comprehensive benefit package that they keep referring to within the white paper still hasn't been adequately defined. I found this following statement that you can find in paragraph 250 of the white paper. Focusing on the question of what the NHI will cost is the wrong approach. I really found this statement not only disingenuous, trite, downright cheeky, but just considering the perilous state of the South African economy and the fact that this program is going to require billions of rands, it could spell disaster for the South African economy. You actually need to get a firm grasp of what the costing figures are. So what does the NHI white paper specifically state about the costings? NHI expenditure increases by 6.7% a year in real terms after 2015-16, resulting in a cost projection in 2025-26 of 256 billion in 2010 prices. These projections would take the level of public health spending from around 4% of GDP currently to 6.2% of GDP by 2025-26, assuming the economy grows at an annual rate of 3.5%. This increase would be below the public spending as a percentage of GDP of many developed countries. So, a number of interesting assumptions and a number of interesting things that come out of there. Unfortunately, there's no hope of the South African economy growing at a rate of 3.5% in the near future. If we look at the figures from last year, the economy grew at a rate of 1.3%, and the economic growth forecast for 2016 is 1.4%. So we can expect dramatic shortfalls in funds. And there's only one place that these funds can come from, since government doesn't have any revenue of its own, and that's taxpayers. Now, this situation is not unique, because all across the globe, healthcare sectors are under pressure from rising costs. For example, here's a headline from the Guardian. It states Britain's NHS is in trouble, and its chief executive has requested 8 billion pounds, which is about 184 billion rand, to save it. Now, if an advanced developed country such as Britain, which has a GDP per capita that's over 3 times greater than South Africa's, is struggling to meet the healthcare demands under their free healthcare for all policy, I think it's simply unrealistic to assume that a poor developing country such as South Africa will be able to afford to do so. And I think therein lies an important point. Government may be able to shift costs, but it can never avoid them. So if it introduces a policy of forcing Peter to pay for Paul's healthcare needs and forcing Paul to pay for Peter's healthcare needs, while Peter and Paul may be tricked into thinking that someone else is paying for their healthcare needs and that they're receiving free healthcare, in fact, in reality, neither are. Ultimately, such a system encourages both Peter and Paul to overspend on healthcare, since neither takes responsibility for their own healthcare needs. So, whenever possible, we should be favoring systems that encourage individuals to take responsibility for their own medical and other health-related needs. So the unrealistic assumptions that I was referring to earlier also raise a number of questions. For example, under national health insurance, in a tight economic climate such as we are currently experiencing, how will the government officials decide which services to provide and who should receive care? And when individuals are forced to make payments into the NHI fund, what will happen to them when their disposable income has all been but wiped out and they can no longer afford to pay for somebody else's free healthcare? So, how much will NHI really cost? Well, I think without the details on the comprehensive package of benefits that the white paper refers to, it's actually quite difficult to say. But if we assume an average cost and a modest cost really of 567 Rand per person per month, which happens to be the average cost per beneficiary of the PMBs in 2014, and we multiply that by 12 months, we'll get to a figure of roughly 6,800 Rand per person per year. And considering the mid-year population estimates of South Africa in 2014, which was 54 million, if we multiply it out, we get to a total figure of 367 billion Rand. Now, considering the total personal income tax take collections for 2014 was only 251.9 billion, we start to get some idea of the futility of this ambitious proposal. I was also intrigued to read what the government and what the white paper's plan was to deal with the chronic shortage of skilled healthcare professionals in the country. And here I'm quoting from paragraph 36 of the white paper. It states, through the Nelson Mandela-Fidel Castro collaboration, a medical training program was established in Cuba alongside the recruitment program. As a result of this collaboration, there are 3,344 medical students training in Cuba as at 2014. The domestic training platform has been expanded since 2011 by increasing student intake, and plans to build new medical schools or to expand existing ones are in place. I think let's start with the positive things first. The increased intake that's been occurring since 2011 should be applauded. For many years, the Free Market Foundation has suggested that in order to alleviate the chronic shortage of skilled healthcare professionals in the country, the government should be increasing the number of positions available at the existing facilities. But I think more can and should be done, because every year thousands of potential candidates are turned away because the number of positions at these facilities is limited. And that number is about 1,500 positions, which for all intents and purposes is not that much greater than what the number was in the 1970s. And this is in spite of the fact that we have a rising disease burden and a population that's more than doubled over this period. So what are some of the strategies? I think a short-term strategy would be to allow more foreign skilled healthcare professionals to practice in South Africa, and not for the government to unnecessarily delay their visas, as well as dictating to them where they should be allowed to practice medicine. A longer-term strategy would be to allow the private sector to establish private medical schools. I think that would potentially give the thousands of people that apply, even those that achieved distinctions in their matric examinations, a shot of actually pursuing their dreams of studying medicine in South Africa. I think that these private medical schools can either operate on a non-profit or for-profit basis. It doesn't really matter. Their establishment can only help in assisting in alleviating the burden that we're currently facing. I believe that South Africa's private hospitals are well-established centers of excellence, and they're world-renowned for their high quality of care. So if the private medical schools are established in conjunction with these private hospitals, I think that a significant part of the burden that we are currently facing would be alleviated, but it could also potentially attract a number of skilled foreign lecturers, which will obviously increase the pool of knowledge within their country. But it will also attract a number of foreign students who could potentially stay and work in South Africa thereafter. I hasten to add that I don't think the establishment of private medical schools will alleviate the chronic shortage of doctors in the country overnight, but I definitely think it will help alleviate the problem in the longer run. I found it highly ironic that one of the themes that persists throughout the white paper, if you read it, is that they want to put an end to outsourcing. And despite this, the government continues to outsource the training of doctors to Cuba. And remember, this is a country that not only has an atrocious human rights record, but it's also one that has a completely different disease profile to South Africa, and not to mention the small impediment of our youngsters receiving training in a completely foreign language. So I thought this graphic from the far side was really fitting to add in there. One of the kind of rationale behind the idea of not allowing the private sector to train doctors is that it would mean that individuals from poor communities would never be able to come to become doctors. And I think these sentiments are wrong on at least two counts. Firstly, the number of positions available at private education training facilities, if they're ever allowed to establish, would not reduce the number of positions available at the existing government-operated facilities. And secondly, there's no reason whatsoever for the private sector not to offer young, bright candidates bursaries to attend those facilities. So I've spoken about some of the costing issues, some of the funding issues, and some of the personnel issues, and now I'd just like to start wrapping up. I think it's important to note that most, if not all, developing countries face the problem of having insufficient revenues to adequately provide for their healthcare needs and demands of their population. And here Bowie and Adams from the Wharton Business School state the following. They say, in the majority of low and middle income countries, the government cannot raise enough funds through general taxation to adequately finance the public health system, and they lack the institutional and organizational capacity to establish a functioning system of mandatory health insurance for the formerly employed. I do, however, believe that health insurance makes sense, but given South Africa's narrow tax base, the high disease burden, and the country's limited resources, how should the government be proceeding with its healthcare reform? Well, I think Alexander Preko, who was the former lead health economist with the World Bank, provides part of the solution. He states that the ability and willingness of households in developing countries to pay for healthcare is far greater than the capacity of government to mobilize resources through taxation. Here, I think that regular small fixed payments to a medical scheme or a private insurance vehicle makes intuitive sense, as opposed to the rare but devastatingly high out-of-pocket payments required when illness does strike. So, as our motto suggests, progress through freedom, I think we must be allowed, people must be allowed to make the choices themselves. I think that private health insurance not only increases access to quality care, but it also improves consumer choice, which leads to greater health system responsiveness overall. And if given the option, the vast majority of people in South Africa would choose to attend a private health clinic. And I think that statement is evidenced by the fact of the significant amounts of out-of-pocket expenditure that's already occurring in South Africa. So to back up that statement, I rely on Professors Sebas van der Berg and Professor Heather McLeod, who state that though the 16% of the population belonging to medical and bargaining council schemes receive good health services, public healthcare quality is so inadequate that 30% of people without medical scheme cover pay for private treatment out of pocket. And I think this also should put to this idea of the 84-16 split to rest. I mean, a lot of people are accessing private healthcare clinics through out-of-pocket expenditure. So I think that part of the solution lies in expanding private health insurance cover. I don't think we should be squashing it, and as the white paper refers to, simply restricting it to complementary cover, whatever that may be. It's not defined. As I said previously, I think private health insurance provides consumers with greater choice and satisfaction, but the regulations that are put in place by government are preventing medical scheme actuaries from actually rolling out low-income options to low-income individuals. So that requires urgent attention if we would like to see more low-income individuals covered by private medical arrangements. And I think to the extent that medical scheme actuaries are compelled to move away from the economic and actuarial realities, we will be creating a situation that is Here, I think that government should not be locking people into this preconceived notion of what it currently regards as ideal, and it should be allowing people to decide for themselves how and where to spend their money. What about the poor? Here, I think government has a very important role to play. It should concentrate its efforts and scarce taxpayer resources on those who truly cannot afford healthcare. And for these individuals, I think the government could act as financier, but it should let the people decide for themselves where to spend their money. I don't think it's necessary to finance the healthcare needs of the entire population, because doing so is not a particularly good use of scarce taxpayer resources. You must remember that spending in one area of the economy necessarily comes at the expense of another. So for example, if the government dedicates more of the budget towards healthcare spending, that necessarily means that there will be less money available for education, policing, sorting out the country's electricity problems, and perhaps even the country's looming water crisis. In order to fulfill the task of acting as financier, which is what I was referring to earlier, I think the government can and should enlist the help and support of the private sector by contracting out those services that can be provided more effectively and more efficiently by private providers and administrators. So, in conclusion, I'd just like to say that for poor developing countries such as South Africa, a system of nationalised healthcare is simply not affordable, given our increasing burden of disease, our narrow tax base, the antiquated infrastructure within the public healthcare sector, the country's aging population, the inevitable increase in demand that will result from free healthcare for all, as well as an adequate number of healthcare personnel. I think that the NHI system will simply collapse under its own weight. And as I said in my opening remarks, that I think it will create a bureaucracy that's for government, that's entirely incapable of handling. For many years, the Free Market Foundation has suggested that if government views healthcare for all to be politically essential, it could require the population to privately and individually purchase mandatory cover to ensure against catastrophic health-related events, but otherwise, as I said previously, leave people alone to decide for themselves where and how to spend their hard-earned money. And instead of the government undertaking the management of taxpayer-provided funds intended for covering the cost of the poor, it should put the task out to tender. In the same way that people have many different options to choose from in household insurance, building insurance, car insurance, and a host of other products and services, poor people that are funded by taxpayers should have exactly the same options available to them. It's not necessary for there to be one single fund. And I think that if this occurs, the competition between the public and private facilities to win the business from taxpayer-funded public health insurance beneficiaries will ensure the best services for the best price. My closing remark is that I think we are facing a very big and important fork in the road that, as I said, it not only affects each and every one of us in this room, but also our children, grandchildren, and generations to come. I think we can either choose systematic deregulation of the private sector on both the funding and the financing side, or we can choose even tighter controls where government is responsible for our healthcare needs from the cradle to the grave. I think we need to recognize this impending disaster and correct the mistakes before they are made. Thank you.